Dr. B.G. Tukral, Radiologist, Safdarjung Hospital. Dr. R.D. Lele, Director, Nuclear Medicine Department, Jaslok Hospital and Research Center. Dr. J.S. Suri, Director, Dr. Suri Path Labs. Ms. Sonal Pahwa, Associate Director, Healthcare Technopath. Dr. Damodar Bachani, Director, Professor and Head, Department of Community Medicine, Lady Hardinge Medical College. Dr. Balram Bhargav, Professor of Cardiology, Department of Cardiothoracic Sciences, AIIMS. Dr. Sai Praveen Harnath, Physician, Apollo Hospital. Some of the speakers are yet to join of the third session, so I'll request them to join as and when they come. And ma'am, if I can request you to, we can start with Dr. Pradeep and Mr. Madhu. So we can start with Dr. Lele and then we can ask.
Good morning, ladies and gentlemen. I have been given a very difficult task because all of the speakers have a very interesting topic and the time is very short. And I hope and I believe we will be able to finish within given time. Now, I am honored to request Dr. Lele to present his presentation on
Mission Mumbai Health.
Mission Mumbai. Dr. Lele is the Director of Nuclear Medicine Department, Jaslok Hospital and Research Center. He is a pioneer in his medicine, needs no introduction, and Jaslok Hospital itself is taking lots of initiative on safety and quality healthcare. So I am sure this is going to be a very interesting presentation. So sir, may I request?
Thank you. Madam Chairman, I am very grateful to give this first opportunity. We have to go to the airport at 1 o'clock. The topic is very interesting and he is suggesting a paradigm shift. But I am suggesting the poor people in the rural as well as urban area need health insurance and also microfinance. That's my theme. And this is going to be a reality. The current scenario is not very successful. Government expenditure on healthcare is only 0.9. And you hope that the present budget will be 0.2%, far below the WHO requirement of 5%. My point is, 80% of the health expenditure in this country, rich or poor, comes from the private pockets. 80%. And therefore, my proposal is, the poor people do not need charity, they need microfinance. I'm going to show you how in the next 6 months we are going to change the paradigm shift. Last year I went to Taiwan, which has a population of 23 million. Every citizen of Taiwan carries his health record in his pocket. He gets his computerized prescription. And they said, we can replicate this in Mumbai. Mumbai, Thane and Navi Mumbai together are 23 million. But I told Taiwanese that I can do better. Because there Taiwan health insurance is making losses because they have not added preventive care. So my paradigm shift is health insurance should be linked with preventive care so that the cost comes down. Today all health insurance companies are making losses. Private as well as public, they make losses of 2,500 crores every year. Plus they give 6% to the TPA for keeping the records. The job of TPA is very thankless. He has to reduce the claim. So my suggestion is, if the medical profession takes responsibility of adding preventive care, the 180% claim ratio comes down to 20%. I am showing you how, in the next 6 months, my Mission Mumbai Health is going to achieve a very health insurance is an integral component of prepaid managed care, urgent need for a paradigm shift. So what I am going to show, what I propose to do in the next 6 months in Mumbai is to implement this idea. The Insurance Regulatory Authority mandates that all insurance companies must do at least 20% for the poor. LIC, I am happy to say, have accepted my principle that for the 23 million people of Mumbai, LIC will take responsibility for giving life insurance to all the breadwinners, accident cover to every citizen of Mumbai, plus health insurance without any exception. How is it going to be possible? By adding preventive care. I have enough family doctors in Mumbai. Each family doctor will take care of 1,000 families or 5,000 members. I am paying them 1 lakh rupees per month for taking the preventive care. It is not charity. It is possible. So LIC understood my plan that in the city of Mumbai, I will employ family physicians. They will create an electronic health record. Ila Bhatt has given a very important message. She says health insurance has to be within the mandate of microfinance institutes. Deposit linked life and health insurance collaboration between microfinance institutes and health sector. Income security and health security are two sides of the same coin, especially for the poor. I did a survey of Dharavi. The poor Dharavi family spends at least 10,000 rupees a year on their health care and they don't get the benefit. So this 10,000 rupees, I am giving a 5-year policy. All he does is to pay 200 rupees per month for the next 5 years and he gets microfinance. LIC, banks, ICICI accepted. The poor will get microfinance. The 5-year policy, which I have called a brown card, I will show you. What I want to point out, next month in Maharashtra state, Rajiv Gandhi Jeevan Dayi Yojana is going to be implemented. What is this Yojana? Over 20 million poor people allotted identity cards will walk into any public private hospital to get treatment for 972 surgical procedures with free medical treatment up to 1.5 lakh per month. And hospitals must keep 10% of the beds reserved. Hospitals must also adhere to the cost setup. Courts have ordered hospitals to keep 2% of the revenue aside for subsidizing poor patients. What I am suggesting is, the major deficiency of this Yojana is only covers hospitalization. I have done a survey of the poor people in Mumbai. Hospitalization is only 11% of a per month expenditure. 11% only. So 89% is not covered by either Rashtriya Bima Yojana or the Rajiv Gandhi Yojana. So I am suggesting to improve by my bronze card, which I will show you just now. This is a smart card given in Maharashtra. And my recommendation is upgrade the RSBY to my bronze card and provide microfinance to BPL. The poor do not need charity, they need microfinance support. This Taiwan model I already mentioned. This is my plan. Bronze card for those poor people in Mumbai who have got the income of 4,000, 100,000. The annual premium is 2,500. Silver card, gold card, platinum card. Anil Ambani will get a platinum card. The middle class family gold card. But all will get preventive care. Birla, the most rich man in country, Birla, saw in the London airport a poster. If you are a male above the age of 50, get your PSA. Comes back to Bombay, gets his PSA, 750. Silent, prostate in the city. The richest man in the country did not get preventive care. In my plan, every citizen will get preventive care according to age group, rich or poor. And the cost of care will come down. Salient features. Financing and delivery of health care through per capita prepayment, so that the physician organization has a budget for the care it will provide and an incentive to use resources wisely. Maintenance of a continuous healing relationship with the family physician with a voluntary annual population, and I will pay family physician 1 lakh per month for taking preventive clinical care. So no need for practicing unethical medicine because he is getting sufficient remuneration. Physician and multidisciplinary specialists can design and execute best care processes in the most cost-effective manner. Hospital facilities, complex diagnostic equipment, and laboratory investigation are deployed on a regional basis so it can be used with greater efficiency backed by insurance cover. Electronic patient record, which will provide an accurate and comprehensive picture of each patient. EHR will avoid unnecessary duplication of tests, facilitates collaboration and coordination of care, among specialists and allows monitoring of compliance with the practice. Copyright prescriptions to the patient's own language, give detailed instructions. All this is in place. Already a pilot is going on. The Mathadi Hospital, 40,000 workers in its service, their electronic health records are being created. On a 6 megabyte optical disk, the entire family's health record can be there. And there is another option of 2 gigabyte where the entire middle class and high class family can be recorded, lifetime record, including EEG, kind of things. So it's a very revolutionary step, which is already implemented in the city of Mumbai. It's not going further. Can it move further? It's stuck here. Good. ThyroCare, which is Asia's biggest laboratory, have promised me that all the important tests will be given to the poor people at an affordable cost. By 2025, India is going to be the diabetes capital of the world. So each person needs once a year fasting blood sugar. The fasting blood sugar is more than 100. Preventive program starts now. So for 10 rupees, you will get a fasting blood sugar. For 50 rupees, you will get PSA. So I am suggesting that because the bulk goes up to 30 crores, the laboratory can afford. So today laboratories are not affordable, but ThyroCare promised me that all the essential care or preventive tests will be made at an affordable cost. X-ray will be available for 10 rupees. So it's a revolutionary concept, not based on charity, a good business model. Therefore, I am suggesting to you that future healthcare in India, NGO partnership with state governments will only provide micro-insurance. Today's healthcare is only illness care. I am changing the paradigm to promotion of positive health and preventive care. For the 70 lakh poor people of Mumbai, microfinance budget of 15,000 crores is required. At 25% interest is a viable business model. Mission Mumbai Health is not Mission Impossible. Impossible can be broken down into possible. If you give your email address, the organizers have promised to give you the entire details of my Mission Mumbai, and this will be on cloud computing. It's a revolutionary step. It is possible. India can do it. And I hope all of you can help me in bringing this mission to fruition in the next 6 to 12 months. At the age of 85, I don't make 5-year plans, I make 1-year plans. Thank you. I will have to leave for the airport, so if you have any questions, you can ask straight away.
Send it on the mobile.
Please. Mobile will be used as an instrument. Every citizen mobile mobile. So I use full mobile for patient education and keeping track. So wish me good luck. Thank you very much. Any city can do it. The permission may leave.
Thank you very much, Dr. Dilip. It was really enlightening, and the preventive aspect is very close to the heart of most of us who are physicians and healthcare providers here in this room. See, again, there are 2 or 3 of our speakers who need to go and leave and go early. So I'll invite first Dr. Pradeep Mishra. He's the director and program master.
Yes.
Is he here?
Yes.
Okay. And so to present his presentation on e-transformation of Indian hospitals.
Right. Cookies first and now cloud. What next? Okay, so in the IT jargon, I'm not an expert, but I'm a physician. I lived abroad for approximately 25 years. I qualified 25 years ago. My contact with IT came nearly in early 90s, late 80s, when I was working in North Middlesex Hospital. I trained as a chest physician. I have been in touch with IT since then on a regular basis, off and on. So I'm Dr. Pradeep Mishra, ladies and gentlemen. Let me tell you, I think it is now good midday, not good morning. I think I was supposed to speak in the first session. And I'm really privileged that eHealth gave me this platform to say what I've got to say. My topic basically is about e-transformation of primary healthcare, a vision for modern India. I won't talk about my own website much. It is called www.ilajonline.com. You can look at it and you can say and give me a feedback. I've got my email on that. Having worked at both ends of the spectrum, a failing public healthcare system in India, and probably the best and most successful healthcare system abroad, I have now felt passionately about rural healthcare and primary healthcare, and that is what I'm going to talk about. So let us start on a positive note by saying that the decision of the government recently that came in the newspaper was they are going to increase the health expenditure from 1.4% to 2.5%. However, it remains to be seen how much of it goes really to the people who need it most at the grassroots level. And we have stories from Uttar Pradesh, we all know about that. Free access to good quality healthcare is one of the pillars of an egalitarian society. Sadly, India fails miserably on this account. Historically speaking, India never considered health and nutrition of its people to be tackled seriously and persistently. We did have, at least on paper, excellent plans, one of which is worthy of reconsideration even today. The Board Committee report presented as early as 1946 is one such plan made in India much before a declaration was made in Alma-Ata, about which Dr. Annie Chakor mentioned a few moments earlier. This declaration was famously known as Alma-Ata Declaration of 1978. It was organized by and presented by World Health Organization. India as a member state was a signatory to this momentous declaration. So what happened? That primary health care got neglected in a country where it was needed most. Time does not permit us to go into a detailed analysis of the various factors that weaken the public healthcare system in India, but a combination of both international pressure and national apathy may be the reasons behind it. So what was the Alma-Ata Declaration? I'm not going to read it because of the pressure of the time, but it's quite evident. It is a very lofty idea. They say the conference strongly reaffirms that health, which is a state of complete physical and mental and social well-being, and not merely an absence of disease and infirmity, is a fundamental human right, and attainment of highest possible level of health is the most important worldwide social goal, whose realization requires the action of many other social economic sectors in addition to the health sector. So you see, it is a lofty ideal, and the lofty ideals need concrete steps. A robust primary healthcare system is an effective tool which we need at our disposal to make India a strong country, literally speaking. The information technology with reliable infrastructure at the primary healthcare level can lead this movement from the front and support it from the back as well. So So let us infuse this modern electronic energy in proper and thoughtful doses in the primary healthcare sector to resurrect and reorganize this most important format of healthcare delivery in India and gradually improve indicators such as infant mortality, maternal mortality, and many other parameters of healthcare. So you see, people are here at the interface of business, IT, and health sector, and I'm sure I'm the odd man out. I'm advocating for the rural health care, and I'm sure that business people can move into rural health care and provide a backup in a public and private partnership. Now I'll take you to the next slide, and there are the hurdles. You can read it. Poor education, especially in health and hygiene, diverse culture and practices of health care, substandard in inadequate public health infrastructure, lack of will at the political level to improve, top-down or vertical approach in delivery. What are the basic principles on which I suggest the e-health software should be created? You can read it again. Women and children always considered first and actively targeted. Clinical epidemiological data collected quarterly and audited with the help of experts. Each person in a defined population must be a stakeholder in proper functioning of primary health care. Emphasis on prevention and health education. Public-private partnership encouraged. No top-down approach, guidelines developed locally. And what are the fundamentals? Well, you must have trained personnel both in health and IT, regular visits by an IT support service to check the system, computer, printer, fax and scanner, regular uninterrupted power supply, internet connectivity, security and confidentiality of the data, long-term financial plan, upgrading at appropriate intervals. So how are the system and processes going to work? Well, you have got the hub, the primary healthcare in the center, then you have got 4 arrows indicating e-records, e-care, e-resource and e-links or e-linkage. E-records. Now I have enumerated what you can put in e-records. You put unique identification number, name, date of birth, date of death, height, weight, address, and if possible, blood group immunization details. E-care. Now the emphasis is on prevention. So let's look at the nutritional status our Prime Minister has been talking about, such as BMI record, outbreaks, demographic details, source identification of the outbreaks, school health initiative in a defined population, health education leaflets in local language, immunization programs, clean drinking water and waste disposal initiative. We are talking about IT, we are talking about major things in hospital. What about clean drinking water in the villages? People are not getting even clean drinking water in the villages. For God's sake, let's start some program that can give at least clean drinking water in our villages. And you know many diseases are linked with clean drinking water. Antenatal and postnatal checks and protocols, family planning assessment clinics, and this should be audited and evaluated at 6-monthly interval. Then we have got the proper doctoring, as we say, e-care, curative, symptom-based diagnostic algorithms, prescription details linked to pharmacy, chemist or dispensary locally, follow-up, secondary prevention, and developing local clinical risk management. Nobody has talked about clinical risk management. Iatrogenic diseases, wrong operations, wrong prescriptions. We have to look at clinical risk management. We have to talk about clinical risk management in this country. And there are many issues regarding this. And there should be daily audit at a primary healthcare level and also at DGH level by senior clinical staff. I'll finish in 1 minute. Then we have daily sort of costing, cost of running. We have got finance, needs assessment, allocation of money, budget forecast, funds received, and you can read there, so on and so forth. Many things can come into it. Then you can have e-resources, ID for medical nursing, paramedics, CME available for medical workforce, etc. GP roster. And then there are e-links that can be linked to central database. You have primary healthcare center at the hub, and then you have got DGH, and then you tertiary care center, and then central database. You can go through the community healthcare center, and then you can go to the central database. So what about it will now of me not to talk about business a bit. So if you look at the clip that I put up, published in the recent Economist, which I picked up at Heathrow Airport a few months back, it says that the consumer healthcare only less than 20%. you know, and I suppose that most of the money goes into buying consumer products like toothpaste and soaps. What about direct investment, like in vaccines, in drugs, in higher-end medical products? You know, China is capturing that market. We have to do better than that. So I come to my last slide, which I'm going to conclude, and I leave you with the lines of Rabindranath Tagore, and you can read it. But what I have to say is I'm not going to speak about my website. I'm going to tell you what you all are betraying in sitting in this room. You are the elite of this country, and what you should do, you should look at the Rural Health Service, and you should bring people from the private corners in the industry to support the rural healthcare in this country. It is naive to talk that people go and sell their houses and lands, and then you are talking about the elite is betraying this country. Let me tell you, these are strong words. You may object, but elite is betraying this country, and we must not let that happen. Thank you very much.
Thank you very much, Dr. Pradeep Mishra. He very precisely has finished at 12:30, and because the E-world runs on precision, so this is the first requirement, I think. Thank you so much. Now I'll invite Matt Thies, the Managing Director, Dimagi Software Innovations. Sounds interesting. That's it. The Dimagi Innovations.
First off, thank you very much for having me here today to speak. It's an honor to be among such esteemed company. I want to start today by taking you through a narrative that I hope will resonate well with the audience here. So let's pretend I am your patient. It can be a rural area of India, it can be an urban area of India, but I don't always have good access to healthcare. I have few means, and traveling to a medical facility for me is not trivial. It takes a lot of effort to get me motivated and to get there in the first place. And most importantly, I'm sick. The malady doesn't necessarily matter as much as just the point that I have few means and I'm sick. So I visit you for treatment, and I've seen a lot of examples today of phenomenal treatment facilities and the ability to deliver wonderful care. So I received good treatment at your facility. So now I need a follow-up. So I've got an ailment that requires me to come back in a couple weeks or a couple months to continue to get good care. And I go home. And in a lot of situations, what happens next? If I don't come back for that follow-up visit in a couple weeks or in a couple months, who knows what could happen? I could have gotten better because the medicine you prescribed worked. I could still have the same ailment because nothing happened, or I mean, at the worst outset, I could be dead. And the systems don't follow that. Nobody really knows what happened in that scenario. We call it kind of a lost follow-up case. So there's a lot of different ways to kind of address that lost to follow-up case. And in this narrative is a very specific example of kind of one problem that within healthcare, and one area which electronic healthcare has the possibility to kind of make a big difference. And an example that I'll talk about has a lot to do with the work we do in rural areas, so with ASHAs and Anganwadi workers for the NHRM. The ASHA program through the NHRM is an amazing program, employing 750,000 different ASHAs since 2005. Some of those ASHAs do their job really, really well. It's unbelievable what they're able to do. Some of them aren't able to do as well. So across that 750,000, you've got a broad spectrum of capabilities of what they can do. The potential for what they're able to do is enormous. They're all trained in techniques with proven healthcare potential to dramatically improve maternal and child healthcare. But it's proven potential based on the protocols that they're given, and it only will result in improvement if they're able to adhere to those protocols and adhere to what has been clinically proven to be an effective way to deliver care. And then also, as we've seen in a couple presentations this morning, phone usage is kind of blossoming throughout India. There was a paper or an article in the newspaper this morning that there are more cell phones in India than toilets in India, where people have more access to a cell phone than they do to a toilet, which is kind of an amazing statistic when you think about it. And then kind of what is even more amazing is what a cell phone like this today is capable of doing. There's a lot of amazing EMRs and EHRs that we've seen being presented today. And what's amazing is the computing power of this little device is able to do very similar things. Not necessarily to the scale that we've been seeing, but at least as an outreach. In the hands of an ASHA, something like this can be a very, very powerful tool. And so that's where what we have worked on. We worked on a program or a project called ComCare. And it's basically a case management tool that runs on a phone exactly like this, or it runs on a more advanced phone like an Android, or it can run on a tablet. But most of the ASHAs that are running around aren't going to have tablets, but they're much more likely to have a low-end phone like this that is much less expensive and is incredibly powerful. And so what we provide is a case management tool. So using a phone like this, you can go, the ASHA can carry it on their home visit instead of or in addition to flip books that they typically carry. And they can use it to record information, to give counseling messages, to increase their ability to follow a given protocol and provide them with decision support. So it all boils down to a few basic forms that are kind of linked in an intricate way. In a form you can enter anything, so be it kind of text or dates, numbers, multiple choice, single choice. It all revolves kind of around the patient case. So if an ASHA was visiting me because I'm sick, they would just fill out my details in a registration form, submit it. Everything gets submitted from a cell phone via the cell phone network to a server that houses all of the information. And then as she comes back and visits me more often during each of the follow-up visits, she's able to fill out different forms along the continuum of care. So maybe if I was a pregnant mother, for instance, she could fill out a pregnancy form for me, or a postnatal form for me, or keep track of the immunizations of my child, and submit this, all revolving around the case structure that is centered around me, to a central server to track all that information. And once you have all of that information stored in one place, it's also amazing what you're able to do with it today. So this is an example of what we're able to put on the phone. We can put images and video, audio. So this helps low literate ASHAs who maybe aren't able to read what would be on the phone to help them to do their job. So it'll read the question for them, for instance. I don't know if you'll be able to hear this. Not in this presentation. But so it reads in Hindi, an audio recording that reads out the question, and you can put a counseling message behind that question. So if this is an IFA tablet question, for instance, to not only just say, are you taking your IFA tablets, yes, no, but this is the importance of taking IFA tablets. And so it acts as a tool to support the ASHA giving a counseling message, which is useful for especially sensitive subjects that they're teaching on, like family planning. Often they'll skip over those parts that they're supposed to in their job to talk about, but don't necessarily do because it's sensitive and challenging for them. Here are a few features of what the platform is capable of, but I'm going to skip through this and kind of talk a little bit more about the overall strategy. So you're able to collect a lot of information via an ASHA or an outreach worker, and I'm going to start to migrate from ASHA and onboarding to outreach worker to tie it back in with kind of the theme that was e-transformation of hospitals. So starting with the far bottom right, the ASHA collects information and submits it to a server. The supervisor is then able to see the data that is also submitted on the server, so they can see kind of work management. So they can see which of their ASHAs are collecting forms. how long a home visit takes, for instance. They can see high performers and low performers and know how to better manage the low performers. They're also able to see kind of the cases, so they can see if this one particular case needs more attention, then they can direct the ASHA to give that more attention based on the reports that are coming out of the server. And then also you can create actionable data that can send SMSs back to the ASHA or back to the supervisor to give them reminders about upcoming care. ASHA Manju, you've got a visit to take care of in the next 3 days, just as a reminder. Or you can send an SMS to the supervisor that says, ASHA Manju hasn't visited 5 people that all have overdue visits, so can you please figure out what's happening? To kind of reinforce the existing healthcare hierarchy that already exists. So now I want to try and tie it back into what we've been talking about here a lot today. And this is adding one key piece, and that's a clinic or a hospital. If you're able to have a system that is collecting similar type data, talk to the same server, you can now have almost a cycle from the patient coming in and getting care at a clinic or a facility, and recording that information in an EHR or an EMR, and then having the ability to follow up with that patient afterwards. So we come back to this situation where I visit you for treatment, I get great treatment, I need a follow-up and I go home. Now we're able to provide the last piece that kind of links it all together. So an outreach worker or an ASHA or an Anganwadi worker or a link worker, because in urban areas there's a health kind of workforce that's out there already in India. You can utilize a lot of these outreach workers of health facilities to give follow-up care at the home or the point of care in a home, for instance, instead of necessarily at a hospital. So if I go home because I was sick and the medicines don't work, in 2 weeks we can send a message to an ASHA that works in the catchment area that I live in, and she could get a message that says, Matt was really sick, he had malaria, he was supposed to come back for a follow-up visit a week later, he never came back. Here's his address, here's his phone number, here's the medicine he was prescribed, go see how he's doing. She can show up at my door and fill out information on my phone saying, I visited Matt, he didn't come back to the health facility because the medicine worked, he felt all better, he didn't feel the need to go back because he was healthy, which I think is a very common kind of thought process in which people don't go back to a health facility because they don't feel sick anymore. Or the phone could guide an ASHA through a thought process of the decision support of, oh, he still has these symptoms, and going through kind of a logic tree, like an IMCI protocol, for instance, he could say, yes, you need to refer this person back to the clinic, or no, this person is fine, visit them in 2 weeks to see if they're still fine. So you can kind of complete the cycle here between treatment at the facility, client follow-up, and client referral to the facility. So here what we do is we work a lot in the bottom right corner. So far in India, we've got a lot of different projects that involve ASHAs and Anganwadi workers using phones and connecting them to a server. The reason I put in the bottom left the CIDRS logo, that's the Center for Infectious Disease Research in Zambia, is because this isn't a thought experiment. We're actually doing this, and we're not doing this in India yet, but we've got a project running in Zambia where we've got in rural clinics powered by solar power, because it's Zambia, it's a little less developed. We've got a kind of an EMR type system. It's definitely not a heavyweight EMR, but it's recording primary care information, linking it to a server, and then sending that information to the phone of the CHW running around. And we're currently scaling it to 50 rural clinics with 300 community health workers that are kind of all working in the catchment area of those clinics. So let me keep it brief because I know there's a time constraint. And so I just want to conclude and say thank you very much, and that there's a potential to go to the last mile of healthcare using information technology in just kind of new and innovative ways outside of the kind of the standard ways that have been used so far. So thank you very much.
Like they say in India, more people have mobile phones than access to hygienic conditions. So it's going to be a very useful in coming time, maybe more interesting, and thanks. Now, our friend Dr. Balram has to rush back to cath lab. He is a cardiologist in All India Institute. So I requested him to make his presentation first. He is going to tell us about some challenges and opportunity exist in Indian medical technology industry. It's a clinical engineering, or the term now is healthcare management technology, that is HMT. So let's hear from Dr. Balram.
You should put it on this. Thank you, ma'am. Indeed a pleasure to be here. While I load the slides, I'll just tell you briefly about what we're going to talk about. I'll be talking about what are the challenges for medical device innovation in India. We have started a small, humble program at All India Institute in collaboration with Stanford University and IIT Delhi, wherein we are trying to innovate newer devices. And this program is basically, these devices are going to be useful not only for India but for the rest of the world, because they are low cost, and these devices are initially class 1 devices, but then we will be going to more to class 2 and class 3 devices. So this program has been running for 5 years, and this is called the Biodesign Program, and it is a collaborative effort wherein the DBT, DST, NIH, and the US Science Technology have helped us, the institute. So now for in the healthcare milieu, the government is helping tremendously. There are institutions which are helping us. There is some industry participation which is happening, and there are the various models for innovation. Could be either a fellowship program or a teaching program or an internship program, and then you can have incubation grants, or you can have funding and co-development. So in the Biodesign Program, we have trained 21 fellows over the last 4 years, 28 interns. We've got 20 provisional patents, 5 complete PCT applications have been done. We have 9 products under development. 50% have, half of them have human data. We have 1 startup which has spun off from this program, and we have done 5 MedTech summits. Good progress, but more needs to be done. Now what is the problems that we faced while we were trying to develop devices, and what are the healthcare challenges for medical device innovation in the country? See, the health inequity is there. There is impoverishment. There is inadequate availability. There is poor reach and unequal access, and everyone has been talking about it. And the healthcare services are expensive. So India's share of global burden of disease is that 80% of the deaths are Indians, 20% of disability life are Indian, and 50%, more than half, are due to chronic diseases, and more than 1/3 are due to the communicable diseases, maternal child health care. And our infant mortality rate is still abysmal. Our infant mortality rate is about 58 compared to 54 in Bangladesh and 28 in China. So we are still having a major problems with healthcare reach in the periphery in the country. Chronic diseases are going to increase, and if you look at from 2005 to 2015, we will have about 62 million patients of coronary artery disease, 46 million patients of diabetes, 34 million of asthma. So it's going to really double, and it's going to be a double transition. Basically, the infectious malaria, filarial, leprosy, tuberculosis is still not over, and we've got obesity, cancer, coronary artery disease, and maternal child health care still not over, and these problems are there. So we know the expenditure on healthcare has been 0.9% of our GDP, which should be about 5%, and people have talked about it. Dollar spent, international dollar spent, is about 19 as compared to 207 and 500 in the US. 80% of our medical devices are imported, and devices are foreign in technology, product, and even usability. And it is a major concern because they are only for the 20% of the population. These devices, 80% of the population is not able to utilize any of these medical devices, and 1/3 of the patients borrow money either for drugs or for diagnostics or for devices, and there is high out-of-pocket expenditure. If you look at the out-of-pocket expenditure, it's 78% in India, 83% in Pakistan, 61% in China, and it's about only 25% in the US, which is a capitalistic. The healthcare is there's major health insurances, but the per person spent is only 25% compared to 78% in India. And because of this major expenditure, out-of-pocket expenditure per person, 39 million people of our population are being driven into poverty. So it is really a problem, but there is a promising future for medical device innovation because we have a world-class talent. We have people who are doctors, engineers, entrepreneurs who are doing, who have qualified very well in this country. However, I have a statement which I often make at various fora, is that what our doctors, our generation of doctors have contributed to healthcare in India is that no one has to go out of treatment, out of this country for any treatment. Having said that, we have failed miserably in emergency medical healthcare. The emergency medical healthcare is the next frontier which our next generation has really to contribute. That is very demanding. Trauma, accidents and emergencies is the next frontier where we have to really contribute in a big way. This is as far as the doctors are concerned. As far as the engineers are concerned, I think majority of them have to now contribute for healthcare innovation, for medical device innovation. So industry has contributed. There are some local products, local devices which have been done by GE and also by Siemens, and some of these products are getting into the market. But the government is spending a lot on healthcare and healthcare innovation. We have the Innovation Council, we have the Universal Health Coverage in the 12th plan, and this Universal Health Coverage is probably a very ambitious program. But if it takes off, which we all keep our fingers crossed about it, it is going to be one of the finest programs in the world. All preventive, primary, secondary care to be publicly financed free of cost. All tertiary care to be financed through single payer system. Government contracts in private sector for shortfalls to be strictly regulated. We've had problems in Uttar Pradesh and we've heard about that. 75% of public spending earmarked for primary health care. And health, since it's a state subject, central transfer of funds can be done under this program to meet any shortfall. So this program, if it takes off, is going to be really phenomenal. So there is a lot of entrepreneurial opportunities for healthcare innovation in India. I think most of the solutions that we are looking for are 80-90% solutions. We do not want to copy paste what is available in the West. We have to innovate into products, into devices, into diagnostics, imaging products, which are going to be low cost as well as with very small margins and broad access solutions. So investments, there are seed stage funding is not very active. Government has the money, government has been providing the money. Industry is contributing with money and time, and mentorship is very important for innovation. We need people who can train people to be innovative and to develop newer solutions for India. And we have Matt from Dimagi and Vikram Shilkumar from Dimagi has contributed for this. And India's Decade of Innovation has started. The Prime Minister has declared in 2010 at the Science Congress that the next 10 years is going to be Decade of Innovation, wherein India has to innovate solutions which are for the Indian people and they must be rapidly applied. So I think that brings us to a point how strong regulation has to be. I think we have to innovate first before we bring in a major regulation. There has to be a fine line between innovation and regulation. If you have too much regulation, it will kill innovation. So we have to build startups which are very lean and thin, without bells and whistles. Simple products, for example, the Johnson & Johnson blood sugar monitor. It doesn't have the memory, it just monitors blood sugar, and you can write it down on a piece of paper and keep that record. You don't need a huge big memory. It has to be very simple products. And you have to have good ethics and quality, so that when there are medical devices created, there are some amount of quality and credibility created, and then a brand has to be created. So this is my last slide, and I'll say what is the future of medical device innovation in India. State healthcare will create more opportunities for indigenous innovations. Medical talent will flow back from the West, and there will be more and more grown indigenously. Reimbursements will be there and regulations will reach a critical mass, but we have to be careful about that. Chinese devices will enter the Indian market, but we need to be positive about it, that because they are going to spur competition and there will be more innovation in India if these devices are there. And Indian medtech will see a growth of about 10% over the next 10 years. And ultimately it will be the Indian, Chinese and the Israeli companies who will have to unite to produce devices which are there for not only the Indian market, but for the rest of the world. So in conclusion, India offers opportunities for innovation. Talent is there, the market is there. India is increasingly a lab to develop and test innovations for large local market and potentially then serve the global market, because whatever is innovated in India is low cost because of the frugal mindset, and this experiment seems to be successful, and healthcare innovators in India can build a strong brand with ultimately global consequences. So I think in the next 10 years there is going to be a lot of medical device innovation in India, which will be obviously initially class 1 devices, and if for the audience I'd like to explain what are class 1, class 2 and class 3 devices. Class 1 devices are spectacles, class 2 are contact lenses, and class 3 are lens implants. So I think initial development will be in class 1 and class 2 sector, and then more and more complicated devices will be manufactured within India, innovated within India. Thank you very much, and I wish all the best.
Thank you, Dr. Bhatla, for quick, short, crisp, and to the point presentation. Thanks. Now, may I have honor to call Dr. Bachani. He's Director Professor in Head Department of Community Medicine, Delhi College Medical College, and he's going to present his case.
Thank you, Chairperson, for accommodating me because I have another meeting in Delhi University at 2 o'clock. I would like to go a little away from what has been talked since morning, and as you all know, without personnel, healthcare can only remain as a dream. In spite of technology, you require human beings who are well trained, well capacitated to take care of the health of the people. So, and in medical education, we are growing in number of medical colleges, in nursing colleges. The shortage of teaching faculty all across the country because of rapid growth of medical colleges, and that's how we hear many colleges not yet being recognized by Medical Council of India or other institutions, nursing colleges and others. So can technology help in bridging this gap? Just by increasing the age of retirement of professors to 65 or 70 is not the solution. We don't want to require like Dr. Lele at 85 and coming and teaching us. We require some innovative ways of using the technology in medical education. And I'd like to briefly mention what has been the experiences and how we can improve upon. Well, this is a day, traditionally we have been teaching to medical students and nurses. There are lectures, practical exercises and some demonstrations, clinical postings in the hospitals, some observation in museums, particularly in anatomy and pathology and internship program. If you look at what are the limitations of these, they become very stereotyped and very theoretical in nature, not very applied or participatory. There's more focus on knowledge, cramming up, they say doctors are very good crammers, they remember everything. But application of that knowledge is the key. And current system of medical education doesn't give that opportunity. The ways to look forward are innovative ways for medical education which can become more interactive. There can be presentations which attract people to respond to, the students to actively participate. There are some experiments with self-learning modules. Dr. Bhattacharya is here in NIHFW. We have a lot of new modules being developed for medical education. Distance learning has also been tried. I just received a copy of eHealth where now has been shown that many distance learning programs can be there. And now Ministry of Human Resource Development is coming up with virtual classrooms and virtual laboratories being developed not in the medical science but in science as such, so that can be possibility in medical education also. And more case studies in hospitals and community-based situations which are more realistic, closer to the population need to be worked out. The advantage would be it will make our doctors and other personnel more in skill-oriented and real-to-life situations for total development of the personnel. Various technologies that can be used in medical education which have been tried out in many countries are of course the internet is common method. If you look to postgraduates in the libraries now, they don't want to look through journals, but just use the internet and identify what has been the progress in any field. Satellite communication through dedicated satellites like EduSat, and now we are coming up with HealthSat that would be dedicated for health sector. Telemedicine has been tried out at few places, which will not only provide services but also continuous training and mentoring of the people who do not have experts in that field. For example, a medical college could be linked with a sub-district hospital and provide the care. Distance learning models, virtual classrooms and laboratories I just mentioned, and even in many countries they are starting online periodic assessment rather than typical examination in classrooms. Here are some pictures of EduSet that has been tried out. In fact, about 10 years back, Minister has used this satellite for integrated disease surveillance program also, and same model can be used for medical education. In MP, the Forest Department has used EduSet very constructively in training their forest officers and other people in the field, but in medical education we are quite away from that. There have been some experiments in telemedicine. The idea is that specialists are usually available in large cities and big hospitals like AIIMS. In district hospital we usually get journalists and not, there are many vacancies of experts there, particularly the super specialists, and of course in the rural areas we are just depending on doctors who are just MBBS. Can there be a telemedicine program by which we can have consultation process and we can have mentoring and training programs? Here are some of the again examples of this being tried out in some places. Lucknow has tried it out, Sanjay Gandhi Postgraduate Institution, they are actually offering a course also on this. There have been trials in All India Institute of Medical Sciences where JNK network has been established because of the lack of manpower there. PGI Chandigarh have some programs. Amrita Institute in Kochi, Fortis Hospital, Apollo Hospital, all have made some pilot programs, I would say, which are not countrywide but some pilot studies on this. I would like to mention here that NIHFW is planning for a tele-training center. Maybe Dr. Bhattacharya will tell more about it in the next session. And as I mentioned, Lucknow is providing a course in school in telemedicine on biomedical informatics in telemedicine. But I think if we want to expand, we have to do much more. These are again some of the government efforts that have gone into it. Teleophthalmology project where I was associated earlier also, IDSP, National Telemedicine Grid, National Oncology Network for Cancer Hospitals, National Medical College Network is being established, and National Digital Medical Laboratory Consortium. Even Minister of External Affairs had a SARC telemedicine network also to help the other countries. But if you want massive expansion and use of the technology, these are my last slide, about 10 suggestions that we have to invest on. Course website development for various courses of both nursing education and medical college, medical student education. We have to create many case simulations which resemble real life situations. Many times we hear about syndromes, but even our professors have not seen those. Can we make simulation models on this? We have to develop educational video production which will be sort of audio visual and interactive in nature. Educational software application programs, here IT industry will have to contribute in association with the medical fraternity. And then once these tools are ready, we have to have a faculty development workshops so that teachers like me and you are familiar with the new innovative technologies and use them in day-to-day training programs. They will require support in classroom technology support and space management support. Then of course we can begin with whoever are interested. We need to have a network of institutions within the country, and some universities of other countries are also very eager to participate in Indian medical education program. By networking with them, we will require support from industries and institutions to take it forward, and the last but not the least, the government's commitment to it. In fact, government, as has been mentioned this morning, and before coming back to Lady Harding, I was in ministry. The budget has been increased to 2.5% from 0.9% for the 12th plan, and the next plan is going to be called as health plan. So there will be a lot of focus on this, but we have to ensure that within that plan, information technology and communication technology find some space. At least 3% of the budget which is earmarked for M&E should be utilized for innovative IT and communication technology in medical education as well as in medical service. Thank you very much.
Thank you very much, Dr. Vachani. He really has opened up a big world of opportunities in front of us, and now it's up to us to make most of it. Now our next speaker is Mrs. Sonal Pahawa. She is Associate Director at Healthcare Technopact. She is going to present her views. Excuse me, but may I request Professor Madhulika Bhattacharya to come on dais? She is also a speaker in this session. So I request Professor Bhattacharya.
One more announcement. There is a survey form in all your kits, and since we're coming up with an April healthcare IT survey in our April issue, I would just request you to fill up that form and please submit it to either of us or at the registration desk. It will be very nice if you participate in that survey for us to create a report for our April issue. Thank you so much.
Good afternoon, everybody. Firstly, I would like to thank the organizers for giving me this opportunity to represent my organization and share my views. I would be talking on diagnostic market, Indian diagnostic market in today's forum. So, if we talk of data per se, the total diagnostic market, it constitutes of total 4% of overall healthcare market in India. Still, there are clinical lab pathology which constitutes 40%, and there are radiology and imaging which take care of rest of the 40% market. Today, here I would like to make one point that this organized sector in this diagnostic the market is quite fragmented. The only 10% of the health providers are only from the organized sector. By organized sector, I mean the players which are like corporate chains, which are into quality systems, which are into streamlining their processes, and rest of the market is quite fragmented by standalone units, and the only most of the areas in our country, if we leave apart metros, the quality of healthcare we all know today where we stand. No doubt we have come so far from the time we have got the new technologies in the country. Like sir was also mentioning in his presentation that today is the time when we really need to think back about where we have reached. No doubt we have best of talents available in our country and we have best of technology, but it is limited to the top metros, top 8 to 10 cities of our country. That's it. Rest of the population, today's headline story in the Hindustan Times was actually giving a shocking fact, which was like about more than 1 crore of women in the country, they have to travel 47 times the distance between Earth and Moon to just get drinking water. So this is where we stand today. See, importance of diagnostics in healthcare delivery, eminent doctors here, senior professors, they would definitely vouch for it that more than 70-80% of the decisions today are based on the diagnostic results. Because of so many complications, and there are whatever the care providers, they want to be sure of whatever treatment they are giving to the patients. So in that case, if our lab reports and our radiology reports are not trustworthy, if I may use that word, then obviously the quality of care gets affected to a very large extent. We have the pleasure of having ma'am here as the chairperson. I am sure she would agree with me. The level of accreditation as far as the labs and the radiology centers are concerned is still very poor in our country. Out of total 60,000 labs, which we can count as number of labs, organized labs, only 200 are today NABL accredited. So we have a long way to go. Here, keeping my presentation very short and crisp, I would just like to make two simple points here. One, today we are standing at a point wherein we need to think of innovative methodology of taking this healthcare, whatever we've achieved so far in our country, to rest of our country, not limiting it to only metros and the high-end tertiary care hospitals. Maybe when a MRI machine becomes redundant in a high-end hospital, we can refurbish it and take it to a smaller town, wherein it increases the accessibility for those people who are living in that area, and it improves the quality of care for them. And second point is that we need to really work towards getting the accreditation and quality. Today we say that medical tourism is one of the key things for our Indian healthcare market. We are trying to compete ourselves with nations like Singapore and Hong Kong in terms of medical tourism. But we have to get accreditation as one of our key focus areas to be able to reach there. These are the two thoughts which I wanted the group to leave with. Thank you very much for this opportunity.
Thank you very much, Ms. Sonu. These are really very appreciable views, very short but very to the mark. Thank you so much. Now I'll invite Dr. B.V. Thukral from Safdarjung Hospital. He is a radiologist and he is going to share views on trends in diagnostics and imaging. This was from the last session, but let's hear his presentation.
My previous speaker has just spoken a bit about the radiology. I will be touching a little detail and I will be skipping many slides since I have to cover whatever I have to say in 10 minutes. And the number of slides is much more. But this is a gentleman because of whom I am here today. And I say my hello to Dr. Pradeep Kumar. He is also here because of that, maybe. This is a gentleman who invented the X-rays some 117 years ago. And from that invention of X-rays, we have now come to the era of MR, PET and nuclear medicine and radiotherapy. A lot of things have changed because of development in technology and IT and their integration. He incidentally happened to be working in his lab, which I have a photograph here. This was his lab, where he invented the X-rays. And today we have MR suits, we have CT suits, we have cath labs, and we have whatnot, and many diagnostics. He could simply see that the rays which he could not see have different penetrating power, which he utilized for viewing the, or using it for imaging the inside of any structure. Before that, there was no provision to know what is inside the human body, and it was only the dissection of the cadavers or the dead body one was able to find out what is inside the human body. But this thing revolutionized the imaging of the body, and today we are standing where we can see every bit of human body. This was the X-ray on the left side of his wife, which was the first image which he took. On the other side, he has taken an angiogram at that time, using some radiopaque material and injecting into a dead body's hand. And we are now imaging in the cath lab of our coronary arteries and doing angioplasties and all that. This again was early X-ray machines. They gave a picture like this. We could just see the fracture somewhere there in the leg. The clinical use which the first X-rays were put to were the imaging of the bone. Chest X-ray, we could see the heart, we could see the lungs only, we could see other diaphragm and mediastinal masses. But later on with the soft tissue, we had a tough time in imaging the abdominal structures. We could only see our spine, we could only see our pelvis or the hip joints and around that, but we could know nothing about our liver, our spleen, our stomach and all that. So that was a limitation till middle of the 20th century or till 1950 or so, that we were working with these things. Then came the contrast media, which was, the development was going on simultaneously. Contrast media is nothing but they are the drugs or the agents which are used for visualizing the soft tissue structures which cannot be seen clearly by conventional X-rays. And with this we were able to image our GIT by using the entering contrast. We were able to see our kidneys, we were able to see our uterus and other structures and many more things. I'm not going to details of these things because they are not relevant out here. But these were very important landmarks in the history of development of radiology and which made the treatment of the disease, diagnosis as well as the treatment of the disease very easier and simple for the surgeon, physician and obstetrician and any other medical practitioner. This is how we could see the kidneys and the urinary bladder which were otherwise not being seen earlier when the contrasts were not available. They had their problems, but we have overcome even those problems. We lost even patients because of this contrast media. But now the latest generation of contrast media, which are called the non-ionic, and they are much safer than the earlier contrast media. But again, this is a development and again one of the defining moments in the field of radiology. But these contrasts though helped in diagnosing the disease, but they had their own problems that they sometimes caused damage to the patient's kidneys. But we are taking care of all those and using them with all precautions necessary. This is another image which you can see is nothing but the half of the population of the world needs to undergo this at some time or the other, nothing but the mammogram. We all know the breast cancer is one of the largest killer world over, and it is the leading cause of cancer in the women in our country as well. We have screening modalities for breast cancer, diagnosing the cancer early and treating it accordingly and increasing the longevity of the patient. Again, the problem of imaging the thyroid, we came to the field of nuclear medicine, going to the imaging at the molecular level. We earlier had the nuclear medicine as a part of radiology, but later on the radiology was divided into radiodiagnosis, radiotherapy and the nuclear medicine, but again they are coming back to a single platform because of the technical developments. They have to work in unison and in tandem to reach a diagnosis at proper time and for the proper investigation of the patient. These are just images to show that these are the nuclear medicine images. We could even see the myocardial perfusion or the blood supply to the heart, which area is dead of the heart muscle, so that we can take necessary steps. These are our images. So this is just to tell you that by seeing only on an X-ray, we could either see bones or we could either see lungs, or we could just estimate the size of the heart. Nothing more was possible with after that, when the X-rays only were available. But with the advent of computerized tomography, we were able to see all across the mediastinum and every structure was visualized, and we could go deep inside the chest. Then came the era of ultrasound in the mid-80s when we were still students of radiology. We came to know that something has come as an ultrasound. Though it was being used since long for measuring the depth of the oceans, nobody applied his mind to use it for any other purpose, but later on some people use it for going deep inside the body. And we all are aware, I think many of us are knowing the piezoelectric effect which was utilized here in imaging the body tissues. This was an armamentarium in the hands of the radiologist which has revolutionized the management, diagnosis and treatment of the patient and early recovery. But these are all technical points which we can pass over. These are the applications of the ultrasound. Again, another you can call defining moment in the field of radiology. We could see gallbladder, which was earlier not visible unless you do some contrast study using OCG, which is obsolete now. We could see liver, we could see spleen, and we could also see the developing fetus within the woman. We could find out the baby's problems, but there is a problem out here. It was not only the advantage that we could see how the baby is lying inside the womb. It is transverse, vertical or oblique, where is the placenta, it is growing, not growing, dead, alive or whatever. Now we can tell in a jiffy, but we have misused it. We all know about female feticide. We know it. We don't have to do it. We know that there is a PNDT Act in this country applicable to all radiologists, and nobody should be doing it actually. But this is the disadvantage of this technology, just to mention. These are all the pictures of the abdomen which were not seen on plain X-rays, but can be seen by the ultrasound. Again, continuing with the computed tomography, we can see the inside of the brain, we can see inside the thorax, we can see inside the abdomen. Every small organ can be visualized, which was the CT scanner was invented in 1972, though was made available for clinical use in the late 80s. And the guy who invented it was working for an electrical and musical instrument company, got a Nobel Prize for this. It was the first CT scanner where the image used to take about 17 minutes for the single scan. Now we have sub-centimeter, sub-second scanners called fourth or fifth generation scanners, where we can take images within a few seconds for the area we want to scan and see inside everything. The advantage of IT or communication technology has helped us in making reconstruction of the images from the data acquired through CT scan. We can make image in any plane, and we can have multi-gunner restructuring. We can see inside the vessels, we can see the branching and all that. This is the surface rendering of any body part. So every small area can now be visualized with the advent of CT. These are the clinical applications. We can even see inside the tubular organs without even, some of us might be aware of endoscopies, people putting in tubes inside the esophagus and going inside. We can do that without actually doing it. And that is called virtual endoscopy. This is nothing but an application of the software of the communications. I'll just skip through those slides and I'll go to my last slide, that magnetic resonance imaging is the another modality which has come to the advantage of the clinicians, where we don't have any radiation. That is the biggest advantage, and it has got a very high resolution for the tissues to diagnose the pathology or to look inside the human body. And the other advantages that are coming into this are the functional imaging. We can see at what time which area of the brain is functioning actually live. These are the angiographic or vascular images without actually doing angiography, obtained through CT scanners and the MR. No, there is no time further. I'll just say thank you to the organizers for giving me this time to review here. And I'll just rush through just visual images. This is the cell. Now we are coming to an era of molecular imaging. We have been seeing the images of the whole body organs or the smaller parts of that. But now the targets are our molecules in the cell wall, nucleus, ribosomes and mitochondria. That is the purpose of this slide. And with this I say my thanks to all.
Thank you so much, Dr. Chitra. It was a very interesting journey from ancient world to e-world, and some of historical pictures which at least I have seen first time. They were very interesting. Now I invite Professor Indrajit Bhattacharya from International Institute of Health Management Research, Delhi. He is going to speak on diagnostic and imaging trends.
So good afternoon friends, I am Indrajit Bhattacharya. I come from International Institute of Health Management Research. We are under Indian Institute of Health Management Research Society, 26 years old, based out of Jaipur. My talk today is on defining trends in imaging, in diagnostics and imaging, and my pitch is not towards the Maxes and the Sahara hospitals which have been shown in the previous session. My pitch is more towards the rural tier 2, tier 3 less fortunate hospitals which do not have the access to technology. So I start off with definitions, which is HIS, RIS and PACS. Is hospital information systems tracks the patient throughout the hospital stay, text-based. Radiology information systems is examinations to the Department of Radiology, which is again text-based. And picture archival and communication contains the image-based information in the Department of Radiology. Obviously, if we see without the IT, we had the printed films which took a longer workflow process, and with the help of coming of IT and PACS, we have done away with the print, picture-based radiology and the reporting system, doing away and faster work processes which you see. So the workflow improvement has happened, and with the RIS PACS, several facets has been taken off, and we have reached a faster workflow. The technology components are there on the left hand side with the imaging modalities, ultrasound, CR, CTMRs and advanced clinical applications, and the RIS PACS, short-term storage, archiving, web, as well as diagnostic clinical workstations on the left hand side. And on the right hand side, we have the functions of RIS PACS modalities, the advanced applications showing the functions. So the PACS provides a platform for digital workflow solution for radiology. And this slide shows how we have moved from the modality archive to department workflow to the enterprise workflow systems of the current generation, moving on from the standalone workstation to the enterprise image management, having the advanced applications, the integrated RIS, PACS and workstations, and access to the web. So what we have done is we have done away with the time frame which was earlier without the RIS PACS of 1 week's time to less than hours time, with streamlined radiology and hospital workflow, electronic linkages with the referring community, reduced material and labor costs and increased equipment utilization. So PACS driving the digitization of radiology workflow. So if we see the output, what are the results of PACS? We have seen 66% reduction in reporting time, 80% reduction in film usage, and 30% reduction in full-time equivalents, that is the human resources, lesser human resource timing required, which has led to tremendous benefits from workflow optimization. This slide shows towards the PACS database, which has access to the web, to other hospital departments and clinics, and with the earlier, the limited access which was there to the medical record has become faster, and complex ordering and scheduling processes has been reduced with paper-based processes, lessening of paper-based processes with other hospital departments. And integrated radiology workflow has also led to voice recognition and application integration, leading to tighter end-to-end digital integration in the radiology department. The direct database integration between the RIS and PACS has led to simpler systems, eliminating the broker, automated table updates, IHE compliant workflows, and fewer points of failure. So now we have a single monitor giving access to the internet, to the PACS work list, to detailed patient demographies, to patient EMRs, to patient reports and online requisitions. The environment has led to a double-digit growth in the multi-slide procedures, growth in functional imaging, shortage of radiologists we already have, which is an 8% decline in radiologists in the residency since early 90s, which was just mentioned by my previous speaker, has led to an integrated radiologist cockpit with the next generation solutions having the legacy HIS, the computer-aided detection and image matching, the specialized post-processing clinical applications, as well as the integrated RIS, PACS and EMR. So what are the standards which are involved in this? The three main standards are the DICOM, the HL7 and the IHE profiles. The DICOM stands for Digital Imaging, Communication in Medicine, the Health Level 7 and Integrating Health Enterprise. The DICOM is for image-based information protocol used for PACS and digital imaging modalities. The HL7 is the text-based information protocol typically used by HIS and RIS, and integrating healthcare enterprises enhances access to clinical information, ensures continuity and integrity of patient information, speeds up the integration in healthcare environments, and fosters communication between vendors of medical IT. This is the IHE systems transaction overview, which we have several processes and showing up the HIS, RIS and the PACS integrated with each other. This shows the RIS workflow, which has the following processes, which goes from the patient demographies, visit information, etc., from the HIS to the RIS and the PACS. And while on the way back, the feedback is the image availability status, the web images, and the examination status, related billing information and reports. So what are the trends of diagnostics and imaging? The mainstream trends are the cloud computing, which again in the previous session it was delved in on this subject, internet access to radiology information, and the use of computer-aided detection and other tools to cut cost and manage workload. importance of the 3D applications, and in the personalized radiology front, right selection of test, correct performance of test, correct interpretation of data, rapid distribution of data, and disease-based workflow management. Now this is a slide which I have borrowed from the Sectoral Innovation Committee, which has just given the report to the Planning Commission report on the health, which shows we have Dr. Pankaj Gupta, who is here as the consultant to the NHSRC, who has given the suggestion to the Planning Commission for this kind of a framework for health information exchanges at the state level and the National Health Information Network at the central level to build a e-health authority, setting standards, get the architecture right, integration across the systems, ICT for quality of care, and capacity building. Right from the previous speaker, Dr. Bachani has told that a lot of these suggestions have been agreed upon and will see the light of the day in the coming days. In the capacity building front, IHMR in a very small way has been contributing to the healthcare IT. We have done about 3 batches in healthcare IT in specialization. We have joined hands with the Indian Association of Medical Informatics to develop the programs of specialization, and we just got nominated in the 2011 for the Best Civil Society Development Agency for health IT. And we have received the feedback for definitely lack of trained people in health IT and acutely need for implementing enterprise level health IT solutions to increase access and reach of healthcare. We have signed an agreement with Taipei Medical University, and Dr. Lele just was in the previous session just spoke about the Taiwan model, where in each and every person of Taiwan has their own smart card and the entire electronic health record inside the smart card. So we have done an MOU with Taipei Medical University for strengthening the health IT courses and research. We are going to launch in July 2012 a 2 years health informatics specialized program with 60% courses focused on the health informatics. So I leave with this slide. Can I have my images automatically opened in 2D, 3D, 4D depending on the case complexity? And can I use advanced applications to diagnose my cases right now, right here, right now? I think the answers are yes. Thank you very much.
Thank you, Professor Bhattacharya. So, excellent presentation on healthcare management point of view, how the operational excellency can be supported by. I had been given a very difficult task by Divya. See, there are speakers from first session, second session, and this session as well. But I am happy that successfully we could wrap up, and we have only 2 more speakers. Now, Dr. Sai Praveen Harnath is a physician from Apollo Hospitals, and he is going to present his views.
Good afternoon, everybody. Thank you very much for holding on. I know all your blood glucose levels are extremely low right now. Mine is, I know that. Thank you, Madam Chairperson, for letting me go next, and for the excellent speakers who have preceded me. I know I will not be as brief as Dr. Sonal, and I will not be as extensive and comprehensive as the radiologist colleague who just talked. But I want to tell you something new. I think you may not have heard what I'm going to tell you before. So maybe just wake up for 8 minutes and watch for just what I'm going to tell you. I'm a pulmonary and critical care physician. I was in the US for 15 years, moved back about a year ago to India. And fortunately, I've come across something very interesting, which is tele-ICU. And my talk is going to kind of focus on what this holds for the future for India. And I think this is going to be a force multiplier for taking care to the last mile of the rural Indian. It's going to be taking specialty care to almost everybody in this country and maybe beyond. The future, is really ICU, and it's just a pun on the word ICU, because the video conferencing facilities that we have right now really help people with taking care of patients remotely. I would like to say hello to those who are watching on the web. I do know that there are people watching on the web. I got some emails on that, so hello there. Thank you for watching. And what I would like to tell you briefly is that critical care really is a large field. I'm sure, and I hope none of you ends up in an ICU. You're not somebody that you want to meet me in the hospital. We can be good friends, but don't see me as a doctor, because you have to be really sick to see me. And a critical care unit is defined as a place where you have specially staffed physicians, specially staffed nurses, special equipment to take care of patients who are extremely ill. Imagine this is a fracture you're trying to fix in a few days. And this is like the human body is fractured, you're trying to really take care of all the vital parameters in an intensive care unit. Intensive care units, they provide an extremely high level of functioning. They are extremely expensive, and as I'll show you the statistics very briefly here, there's a big demand for ICUs in India especially. The supply is not as much. There are quality issues, there's accessibility issues, there's availability issues. There's an organization called Indian Society of Critical Care Medicine now, just started recently, it has over 6,000 members. There are specialty ICUs and there are all-purpose ICUs. There's different kinds of intensive care units where patients can be taken care of. As you notice, I'm doing high-speed talk, just like high-speed rail, so just try to bear with me. And there's some data which is out there. There's a lot of facts which we gather from the West, but fortunately in this field, there is some Indian data out there. And the ICU in India, there are some good studies out there which have shown what exactly is the current status of the Indian ICU. One of my colleagues and partners in one of the companies we run is Dr. Ramakrishnan, who's actually in the audience. He runs the Indian Society of Critical Care Medicine, and he actually published a study talking about the cost of intensive care in India. And the cost is quite a bit. There are about 70,000 ICU beds in India at this time, about 50 lakh admissions or 5 million admissions per year. There is, however, no money. 80% of investment in ICU care is in the private sector, 80% is paid for by the patient, 40% actually sold their assets or borrowed money to get into an ICU, and very unfortunately at 2 weeks of time, most patients go home. Either they're alive or they're dead. They're dead because their illness got them or because they couldn't pay for their care. Very unfortunate but true statistic. One episode of illness pushes about 2.2% of Indians into below poverty level. And the initial cost of care is what's extremely high. And it is cheaper than the West, probably because of labor costs, supply costs, and the re-sterilization that we do in India. The disease burden in India is a little different from the West. It does include tropical diseases, seasonal diseases, disasters, epidemics, trauma, as was spoken by the earlier speakers. And there are challenges. There are the 5 E's, I call them. Equipment challenges, expertise challenges, efficiency challenges, economics, and ethics. Ethics is very important because doctors in India are losing ethics. Unfortunately, it is a true statement, and it has not missed the critical care unit. And all these factors are really affecting the care that the common Indian is getting in the sickest time of their life. Critical care is expensive care, like I mentioned. Averaged about 3,000 rupees per patient per day many years ago, much higher now. In the US, it is not too different. There are about 6 million patients get admitted. 10% of hospital beds in America are ICU beds. About 30% of the hospital cost is in the ICU, and over 50% of ICUs are in small hospitals. That's a cartoon from Atul Gawande's very nice article in the New Yorker magazine, which really describes what an ICU involves. I'm getting somewhere with all these facts here. You'll see in a minute or so. There's something called the Leapfrog Group. The Leapfrog Group is an organization in the US, which is a group of extremely large employers who have a lot of patients. About 30 million patients are paid for by insurance companies to the Leapfrog Group. And they went and said, we need better ICU care. And their solution, their treatment was the doctor. The doctor is the prescription. You need a better system of taking care of patients in the ICU. We need more intensive care doctors. Unfortunately, there are not that many. It takes a lot of training to get an ICU doctor. And there are not as many, not just in the US, but even in India, there's not enough ICU doctors. So I think telemedicine fits in here. Why does that fit in? Because why is telemedicine important in critical care itself? We're talking about patient safety. If you have a hospital which has a telemedicine ICU, you can really talk about patients who can get a safer level of care. You increase the quality, the hospital's reputation goes up, you build relationships with remote hospitals. The small rural hospital is now tied up with a big hospital, and the rural hospital may not have to transfer the case, they can take care of the patient right in their own hometown. You also have redundancy, where if the home doctor has to go away on vacation, the tele-ICU person can take care of the patient, and resource utilization can be improved. That's a quick picture snapshot of what this involves. You have multiple monitors where you look at the patient continuously, and there's a supply-demand gap, as you can see on the left side, where there's the optimal utilization and the actual effective supply of critical care doctors. And the right slide shows you the number of tele-ICUs in the US. There's about 41 centers or so where they take care of about 6,000 ICU beds in the US at this point. Now, those are the different centers in America which are having actually command centers for ICUs. There's good evidence for benefits of intensive care in the US at least, where you have a decreased level of care and decreased length of stay and improvement in mortality actually. Can we do this from India? The answer is yes. I am actually part of a group that is taking care of patients in America sitting in India. The fact that this involves really a broadband connection and an extremely sophisticated process where you make sure that trends in patient care are monitored regularly. You also have data showing that tele-ICU care can save lives, it shortens ICU stay, it saves money, almost $10,000 per patient, and you actually get more efficient because the community hospital can see more patients at this point. The benefits again, it decreases your carbon footprints. Patients don't have to drive away from the rural area to the big hospital. There's a large study which came out in JAMA, the Journal of American Medical Association last year, which actually showed that mortality improves, the length of stay improves, and the patient workflow is slightly different. There are, of course, challenges. Now, the staff may say, you know what, we don't want to be seen by other doctors from somewhere else. Patients may not want it. There may be cost issues, and hospitals may not be able to afford it. Power supply may not be there. However, despite these challenges, telemedicine is here to stay. Tele-ICU is the next frontier. AICU is a company called Advanced ICU Care based out of the US. This is a company that has set up a branch in India, and we are part of this branch, and we actually take care of US patients in India. Early adopters are examples of this company I mentioned. The other company which myself and my colleagues have started is called 24/7 Health Vision. And Apollo Hospitals, Fortis Hospitals, and looks like other hospitals including Max and Narayana Hrudayalaya have all embarked on tele-ICU models. The structure of a tele-ICU involves having the technology piece, having the right people. You need a manager, you need doctors, you need the patients who are willing to take care of this. And of course, money is the bottom line, where somebody has to pay for this. And wherever there's money, there's lawyers not too far behind who want to make sure the legal rules are met. Who pays for this kind of a system? It might be the patient, it might be the third party, it might be a hospital, it might be one of us. Taxpayers may decide that, you know, this improves care, maybe we should pay for this ourselves. And that might be where we're heading in the future, especially if we do not have enough doctors to take care of sick patients. Future directions involve technology innovations, indigenous products like our colleague from AIM spoke. You know, we can make these things in India. iPhone smartphone monitoring. There's a company called Airstrip which actually Bluetooth live feeds monitor data directly to your smartphone. Data analysis. IBM had a little ad where they're actually analyzing one neonatal ICU patient. They're getting 43 million data points in a 24-hour time frame. And they're analyzing that to see are there any trends in this. So there's all kinds of large data set analysis, all kinds of new information coming out with research in tele-ICU. I think the next steps are to explore the frontiers of acute care telemedicine. I think we are seeking willing partners who want to pilot with us, who want to try this in the public or the private sector. And we really want to catalog this journey because this is not an easy journey to take. And we really want others who follow behind to have a roadmap to follow. Because ultimately, we're all doctors and this is all about patient care. Ultimately, we exist because of patients. And if the patient's life and the patient's care can be improved, that's really all that matters. Can we do this for India? I think it's a resounding yes. And we have formed a company called 24/7 Health Vision. And we're trying to take this forward where we'll help with the process of actually taking care of critically ill patients around this country and the subcontinent by developing an efficient process which really simplifies healthcare and simplifies critical care around the world. Thank you very much. That was a quick speech. Thanks for paying attention.
Thank you, Professor Saibali. And true to his claim, many of these things he didn't know earlier. So now I invite the last speaker for this session, Professor Madhulika Bhattacharya. She is Acting Director, National Institute of Health and Family Welfare.
Good afternoon. I think everybody is now waiting for lunch, so I'll make it very short. First and foremost, let me make a clarification. I'm Professor and Head, Department of Community Health Administration, and I was Acting Director 2 weeks back. I'm going to speak about public health. We need more of these innovations in public health where 70% of the Indians reside, and only 30% of them have access to the healthcare. So what are our expectations for the public health? To provide best quality care to the community. And I think ever since I came, I've been listening to many of the innovations which are very, very useful for those 70% population who are residing in the rural areas. Our 12th plan document by Government of India is also playing a lot of stress on the use of IT and use of mobile phones, use of Skype, telemedicine.
other audiovisual medias for training and teaching. We have been hearing them since morning. My focus is on use of GIS in health. Why did we suddenly have this demand for medical technology? Because of trauma. And I would like to prioritize the groups which need really more care for IT. I know we have been speaking about all the clinical things in the morning. They are very, very essential. But something which are leading young people to die, something which old people need, and that is for the trauma, for the aging population, and newer treatments getting costlier. So we have heard about all the cut-in costs which can take place if we use the IT. But it has to be affordable, accessible, awareness about the use, because if people do not know, nobody will come forward to use it, and the availability in the rural areas. So now focusing on our aging population, our teaching, training, and our trauma centers, we know that these senior citizens are staying alone at home and they have nobody to take them to the hospitals also. Suddenly they fall sick. So we would like to see how they can be given medicines at home. You have been seeing many ways and many things that are already being done. Telemedicine has already been discussed. So we can have this telemedicine system. The whole thing can be done by the person sitting at home. He sends a message across in his mobile to the monitoring device, to the service center where the nurses and the physicians who are at 24/7 monitoring, they make a diagnosis, they suggest some treatment. Either the message goes to the ambulance or it goes to the pharmacist who takes the medicines and delivers it at home. And they can be working through the medical insurance company also. So this system, it can be set up. It will be really a boon for our aging population. We are nearly 70 million in the country and it is increasing. What about others? The trauma patients. We know that one person is dying every 2 minutes and 50% of them die within the 15 minutes. If we can save them within those 15 minutes and take them to a safe place or attend to them, maybe we'll be able to help our trauma patients. So we can have, using the GPS and the GIS, real-time users have the ambulances, and these ambulances using the GPRS and the GIS can be rushed to the place where the accident has taken place, or even in other emergencies. It can rush to the place and take back the patient to wherever is needed, to the nearest hospital. So we have this use of GIS in a disaster. I said an emergency, I said trauma. In a disaster. And a disaster, through the GIS, you can focus on the area where you have to go, and then you can look for which are the nearest hospitals around, and then take the shortest route, again using the GIS and the GPRS, to reach to the hospital in case of an emergency or a disaster or any accident. Of course, telemedicine will put you at the center and you can get, even people sitting in America getting treatment here. So why not our rural people who are sitting in India only to get treatment in India through telemedicine? So what all can GIS do for our people and for the healthcare? They can provide help in the operation services, for service delivery, for disease and risk factor mapping, for time trends, for helping in environmental health, natural disasters, education and research, medical care, and of course go into more sophisticated modeling. Another thing which I would like to focus on is the education and research, and since I am at National Institute of Health and Family Welfare, we are looking at all the trainings in the country as far as NRHM is concerned, and I think this IT training also becomes a very important part of our institute. We are already into forming platforms for e-learning training, and we are already using the Skype for monitoring the training across the country. I think that's a very good idea. I mean, we are using it for monitoring. That sitting at NIHW, we monitor the trainings taking place across the country just by using the Skype, which of course has to have a hardware, that is the tablet or the notebook or the computer has to be there, but at least we can use the Skype, speak, take lectures, see the arrangement, ensure the resource persons are there and the trainees are there. So that is one thing which we can use as far as IT is concerned for improving the quality of the training. But what are our constraints? We have lack of resources, and this is where I have come today to SOHM to see that the corporate social responsibility of our industries really take care of that they provide the resources, trained manpower. We need more of training in IT. We can have any of these things, but each of them, which has been described today, needs lots of trained manpower, which we don't have in the country. So a lot of training is needed. Lack of softwares. Of course, we have heard like the company Dimagi, they came up with a very good idea, and just let me tell you, just in the morning only before coming here, Intel is doing the same thing. They have also come up with the same thing, which also prepares reports and things. So many organizations are working on it, and I think for a big country like India, we do need many organizations. We should not look to one organization to do everything for the whole of the country. So we need more and more of you to help us in having an effective healthcare delivery system being implemented in the country. Lack of expertise needs to be there. Lack of data sharing people do not like. We need data not only on health, but for health we need data on other sectors also. Roadways, housing, water and sanitation. Dr. Pradeep Mishra said water and sanitation. First we need to look at that. So we need so many intersectoral convergence of data also, along with GIS, which we can help if there is sharing of data, and a policy needs to be there, like a policy for IT regulation, a policy for also sharing of data, interministerial sharing of data, so that we can take use of IT properly and take it forward for having an effective healthcare delivery in the country. So our medical technology should be linked to CMEs, that is continued medical education in health institutes. We should have development of an affordable healthcare delivery model, not the very expensive ones, and I look forward to our industries helping us in that, and expansion of, if not free, let's go in for the public-private partnership models. At least that way the industries can help us for having an effective healthcare delivery system in the country. And thank you for your patient hearing. Thank you very much, and thank EHealth for giving me this opportunity to be with you here. Thank you.
Thank you so much, Professor Bhattacharya. Now, we had speakers in this session from first session, from second session, and the third session, and we could wrap up in reasonable time. So my presentation, I could see that it is covered by, most of the points are covered in the speakers before me. So there is no point holding you back from your lunch. Anyway, it will be loaded on the website. You can go through it. The few points I would like to make. When I was making my presentation, I was really wondering. I was trained as a doctor, and then I was asked to speak on engineering. So it itself shows that how engineering is taking over the healthcare. And now there is a new stream, clinical engineering. So the clinical engineering is a new stream, and there are lots of institutions who are working, like Dr. Praveen has told us, previously Dr. Balram, who is a cardiac surgeon in All India Institute, he has told us. And there are many institutions like Trivandrum, Shri Chitra, CMC Vellore, IIM, IIT Madras. They are working very closely with clinicians on innovating medical devices, medical equipment. And a new thing is coming up, that is called healthcare. Okay, I'll go that side. I promise we'll finish it very shortly. Okay, so this is a new thing, healthcare management technology, or HMT. That's going to be a very close part of healthcare industry. Already has become, in fact. There are medical devices, there are medical equipments. Medical devices are article, instrument, or apparatus or machine that is used in prevention, diagnosis, or treatment of illness. Then medical equipment is used for specific purpose of diagnosis and treatment of disease or rehabilitation. Now the topic for this session was, and it was supposed to be the first presentation in this session, what are the opportunities and what are the challenges? So the few things, I think the first opportunity is to develop guidelines and protocols for various healthcare applications, where equipment safety is critical component of patient safety. I am coming from a organization whose existence revolves around patient safety, so there goes my first thought that there should be standards for it to promote cost-effective use of medical equipment along with patient safety. The second opportunity may be awareness about equipment safety itself. Because wherever equipments are being used, there are always a scope of human error, and it is coming in light. The people are started talking about it. It's like how these equipment errors contributes in casualty. Then the third opportunity may be to develop trained personnel for maintenance. We can start some training and certification programs, and the training for the users, for the staff in the hospital who are using these equipments, medical technology. Other opportunities may be public-private partnerships, device incident reporting, internal review, and sharing it with other bodies, and techno-vigilance, that is innovative healthcare, just like pharmacovigilance. Then teleradiology and other things, we already have heard about it in detail from previous speakers. Then this micro-electromechanical systems, mobile applications, or then what are the challenges? Again, speakers before me elaborated on this, like how grave the situation is. And like Mrs. Pava mentioned, and I agree, it's a horrible fact that Indian women travel 27 times the distance between moon and earth just to fetch water. So here lies the challenge of innovations, especially medical technology. And Dr. Praveen has beautifully described it, that what are the challenges, what are opportunities. These are in different words, I would say. And now here comes what's the role of accreditation. What's the role of accreditation in medical technology? So NABH standards address this issue in one chapter, which is called Facility Management and Safety. It is chapter 8. There are 3 standards, and then there are objective elements behind these 3 standards, and these are being audited during accreditations. These are the few points which are specifically being reviewed during assessments or audits. Like when our assessors, auditors goes, we see how the budget are planned for equipment to start with. Then what this equipment purchase committee functions, who are the members, how they plan, how they project the future requirement. What is the plan for preventive maintenance? What is the plan for calibration and traceability to international standards? What are the measures taken for employee safety? Then documentation, record keeping. And this is, of course, one of the first and important requirement which is being reviewed during accreditation process, the legal and regulatory compliance. Very important is Atomic Energy Regulatory Board requirements, where most of the hospitals have to, they face challenge because there is not much awareness. And so NABH has started education workshops, especially on this topic, like what are the legal requirements, what are the proper waste management after equipment use, like nuclear medicine waste or radiation waste, proper signages, no smoking policy in these areas, and periodic regular review of effectiveness of the system. Another few more points during accreditation process which address the equipment part or technology part is safety plan, which is an essential requirement for every healthcare provider. how the safety committee is being constituted, what are the terms of references, how they document their minutes, how they fulfill their responsibilities, whether this material safety data sheet exists in the organization. Then there should be a system of continuous monitoring and analysis of sentinel events. Many of you here in this room, I can see, are from accredited hospitals, and you very well aware. This is the requirement in coming time, which can help in medical technology industry to control some of the abuses related with that industry. Okay, I will not go into detail. These few slides were made for in various areas how a different objective element addressed to that particular area. I will not go into detail of all these. So here comes the last slide of my presentation. Thank you.
Thank you so much, ma'am. Without your support, we would not have been able to manage the time. This thing. Can we now, since we have another 2 minutes, that if we can take 3 questions before we close for lunch. Just 3 questions.
Yeah, I was hearing about quite a few things, latest developments in the health industry. I have a very simple question to the last speaker from NABH. I was traveling in eastern UP, and we did some water survey for a few hospitals which are supposed to be NABH accredited. Unfortunately, we found arsenic content in the water being used for drinking by the patients. Now, how safe do we consider going to those kind of hospitals, which are supposed to be accredited by some chance? That's one aspect. We talk about telemedicine, that a sick person is at home and he needs some support and some support as far as medicine is concerned. And through telemedicine help, you give them or prescribe some medicine. The water he's going to use, maybe whatever source, are we able to give good potable water for them? Because the moment you take medicine with something which is not really pure, it's going to change the characteristic of the chemical characteristic of the medicine. So how safe is it? Thank you.
Thanks for raising this issue. May I request you to introduce yourself?
I'm Dr. Nandi, representing TQS Global UK Limited in India.
Okay. And
we are basically into health sector, food safety, and we adopt people who cannot really afford safe food or maybe a good lifestyle. So right now we are working for the food industry. Basically we are picking up street vendors and all, developing them. And while we doing that, we basically be recognizing the families of these vendors, where we're doing insurance for them. But while we do the insurance, we need to check up the kind of water they're taking and the food they're taking. While we do all these exercises, we come to know about a lot of facts which actually stark us.
good, so I can understand your concern for working in this area. The second thing which I would like to know from you first, before answering this question, is that you are talking about the accredited hospitals or the in general all hospitals?
Yes, 4 of them are accredited hospitals in Eastern UP.
Okay. So, you have raised the question about the arsenic level in potable water. Okay. See, in all hospitals, different areas have a different requirement. Suppose if a hospital has a dialysis unit, they have a different requirement. They have to use the RO water. Say in OT, they have to use RO water again in ORs or in operating rooms. For say in kitchen area, probably they may not need for washing the utensil and other things. So the different requirements are there. In NABH standards in quality health here. And before that, I would say there is a legal requirement. There are state pollution control committees who needs to inspect healthcare facilities regularly. and giving the report. They address the water pollution, they address the solid waste disposal, then even the noise pollution, air pollution in these areas. So all these certificates we review. The second thing is that because these are directly related with clinical safety and the patient safety. So to make doubly sure that patient should not suffer, we insist that there should be a water testing from hospital side, and the certificates has to be there. They need to maintain the record, they maintain to the prescribed level of the various chemicals. It is our I think this will satisfy your question.
Just to answer, your RO doesn't take off the heavy metals from water. Second, a lot of institutes, government institutes as well as the hospitals, they don't have a pre-planned schedule to clean their overhead tanks. A couple of hospitals I have found lizards or maybe some animal lying in the tank, which is highly risky for people's safety. As far as health is concerned, yes, it's a big risk. Here I'm trying to bring out. I'm trying to talk about the basic practical problem that people are facing now.
Now, Dr. Pranit, who is a chairperson of our technical committee, will also share his views.
I think the feedback that you got is very important. Let me tell you, NABH is not super regulated. So if I come to your hospital and you have the local regulatory clearance with you, I cannot question that as an NABH, right? So I have to take it on face value. But having said that, the feedback that you've given is very important. I would suggest drop in a line on info@NABH so that something can be triggered in a manner that your organization is already working on food safety. We can integrate with the food safety department at district level. Probably this is going to be done at that level to bring these kind of things into picture and take corrective actions.
Yeah. Thanks a lot.
R&D specialist in health and care and animal care. We have spoken each and everything and want to give the benefit from the grassroots level in India. India is having 1.2 million population. WHO says every 50% is mental and private person. From all universities of medical sciences, they have stated 32 million people are suffering from diabetes and 65 million from cancer. And they have given a data. So much people are suffering and there are no medicines at all. Who can provide these medicines? The first step India should have in industry-based production of quality medicines and distribute it to the grassroots level, not at the cheap level to foreign countries. They can give a fiscal rate to India, to their grassroots level. But if America is charging a sum of rupee INR 10 lakhs for one patient, India should give the medicine to America for 100 rupees. How India can compete America? How India can compete China? How India can compete Germany? Never. Once you have your production rate at the rate what they are charging from you, analogous at international rate, only grassroots level patients in India can be cured and they can be well washed with Indian medicine. This point had not been taken, and e-production, e-continuation, including all villages in India, is the only media that could prolong for everything.
Okay, thanks. We appreciate your views.
I just wanted to question the healthcare IT experts. I had a very, I should say, a pertinent question which is relevant to my practice. I'm a clinician practicing family medicine, a humble healthcare professional, but a very fundamental question. I would like to ask about the clinical decision support systems. the fundamental premise that we are using automated systems to decide our diagnosis. I have certain views which I would like to express. The House is open to question and deny. But basically, what I feel, there are two paradigms. One is that it's a specialty care, and one is primary care. Now, specialty care, I understand. If the case of a patient has already been diagnosed as being a cardiac patient, there are certain protocols the United States is following an evidence-based and a CDSS type of format. But in the Indian setting, I feel where primary healthcare practitioners are so much in dearth. I feel that, this model of CDSS, should we label it with a caption, with a caveat that it should be implemented, one, I feel, especially in the specialty care settings, but with a word of precaution in the primary care settings. That's one. And second, I feel it would be really successful, it's just a suggestion and a food for thought, that it would be really successful in the hospital level scenario. But again, in the PHCs, in the primary healthcare settings, if we are making our doctors so dependent on automated, are we not mechanizing the medical thought process at the base? I would like to just put this question to the forum. If this could be really thought over and reflected at least at the clinicians level. That's my first question. And just another, an addition to this question is that I read a research article by one of the American journalists on EMR, electronic healthcare records and medical records, and they said that if a doctor, a primary healthcare practitioner or a normal physician enters into too much into EMR, is he somewhere, if he just blindly, kind of renders himself to the EMR, is he somewhere losing himself out? Or because it's in a way, it's a lot of redundancy. You are managing data and data and data. Don't you get lost in managing data? So I would like to ask, especially Dr. Dinesh Jain, Mr. Mani, and Mr. Gunjan Kumar, wonderful presentations and really relevant. I am a doctor who is really IT savvy, and I appreciate the technology to the core. But the fundamentals cannot be, ignored. That's my humble premise. Thank you.
I would say they both are complementary to each other. So, but still, if Dr. Praveen would like to give his views, or Dr.
I would love to hear.
Thank you. I think your views express what, when the best doctors in the world are Indian doctors. It's recognized around the world. And the reason that most people get it is that Indian doctors are very thorough. They touch the patient, they talk to the patient, they hold hands, they feel the temperature, but they are also savvy in terms of using technology. So I think you really need a mix of the art and science of medicine. There's really no one formula that works. The fortunate thing is that the human body is the same whether it's America, Mongolia or India. So I think clinician decision systems, computers are here to stay. I think we should not shy away from them. I really think they should be incorporated into primary care, especially because there's a shortage of primary care doctors. You don't need a primary care doctor to diagnose somebody with hypertension. An ASHA or a nurse could diagnose hypertension. The primary care doctor could assist with his expertise in titrating the medications. So really, we may need to look at a different paradigm of how we treat primary care. So I think I somewhat disagree that clinical decision support systems are not useful in primary care. I think they really should be integrated across the board. And I really think that technology and health IT is here to stay. The graphical user interface can be different, but I really feel that the next generation of doctors will be using healthcare in every step of their medical decision making.
I appreciate that.
I just want to make a quick comment that the speaker on primary healthcare and clinical medicine and evidence-based medicine. I just want to say a few words on that. Any system in the world is as good as the people who run it. No system can get better if you are not putting the data truthfully. If you are cagey about it, if you are hiding something, well, it presents you with the opportunity to get better. There's a dictum about computers: garbage in, garbage out. If you put a good data, you get a good answer. About the clinical decisions making, you have to look at evidence base. Evidence base goes to clinical epidemiology. They are both contradictory statements. Clinical is about patients, epidemiology is about population. But clinical epidemiology is a very well established branch, and you can look at evidence on PubMed and Medline. You can do a search and you can come with the answer. Suppose somebody comes to you with diabetes or latent diabetes. What are the steps you're going to take? Has this study been made in India on such cases? You can glean data from that.
Sure.
There are Medlines and PubMed which will give you for decision making. But I agree, even in primary health care or anywhere, there should be some kind of process where you should be able to get those data. So I suggest that we create diagnostic algorithms.
I would agree, sir.
Where you put symptoms and they give you the answers. And that has been done. It's nothing new. And it can be easily done.
Sir, but a point to add here. Are we replacing doctors with automated algorithms? I mean, primary healthcare doctors for that matter. I'm just asking. I mean, dare to ask.
The therapy consists of two things. One is the information and the data, and other is the personal touch.
Yeah, excuse me, but on lot of requests and demands, may I request that rest of the questions and the views can be taken during lunch. We can interact with the speakers and among ourselves.
Yes.
That's fine.
With that, I'd like to thank all the speakers, sincere gratitude for all the speakers who have made this session possible. May I request Dr. Gayatri to give away mementos to our the speakers on the dais. And can I request my colleagues Shelly and Mansi to please get the mementos. Professor Indrajit. Dr. Ram. Dr. Saitani Hanna. May I request Dr. Pradeep Mishra and Mr. Matthews also to come. Professor Madhulekha. Mr. Thies. Ms. Sonal Pava. And may I request Shelly to hand over the memento to Dr. Gayatri. Thank you so much for your patience. We'll meet again in 20 minutes at 2:30 and the next session will start at 2:30.